afternoon. Reporting for Team 7 News, I'm your anchor, Courtney Smith. In tonight's news, healthcare reform, from past to present issues and attempts to resolve them. A number of states have developed unique approaches to extend access to healthcare to their citizens. Our first story, Hawaii's Prepaid Healthcare Act. Long before there was a national debate about universal access to healthcare, Hawaii tried to provide all of their employees with some sort of healthcare coverage. With more on this is Julie reporting us from Hawaii. Julie?
Thanks, Courtney. Here in Hawaii, we have seen a major increase in insured people due to the activation of the Hawaii Prepaid Health Care of 1974. This act was enacted on June 12, 1974, and mandated that all employers provide a standard state-established health insurance package for employees who work 20 or more hours per week. The program requires both employers and employees to share in the cost of the health insurance package. Employers paying 5% while the employees paying 1.5% of their monthly salaries towards the monthly health insurance premium. The Act requires a minimum set of basic services, which include hospitalization, emergency treatment, surgical services, physician office visits, laboratory tests, radiology service, and maternity services. Health insurance here in Hawaii is less expensive than in the mainland because this act requires all employers to provide insurance, so there is less need to subsidize health care for uninsured individuals. Another reason why health care is cheaper here is because Hawaiians experience a lower rate of hospitalization and higher rate of outpatient physician visits than in the mainland, which means premiums can be reduced. To show how successful this act was before the law, Hawaii had an insured rate of 70%, and after the law was enacted, it rose to an astounding 98%. Now, if that's not success, I don't know what is. Right, Courtney? Now back to you.
Right, Julie. Our next story, another successful case of healthcare reform, the Oregon Health Plan. This plan functioned more as a mechanism for defining the benefits package rather than a rationing instrument for payment of healthcare services. Coming to us from Oregon is Jin to detail the OHP. Jin?
Thank you, Courtney. Here in Oregon, we have the Oregon Health Plan for the state's Medicaid program. The Oregon's Basic Health Service of 1989 expanded Medicaid to low-income persons and determined who would be covered based on values assessed in town meetings, health states, treatment effectiveness, and priorities based on the commissioner judgment. Who would be covered was determined by the budget and a cutoff line based on a list of priority treatments and diagnosis. It was later revised to be more subjective than the original proposal by elimination of the quality of life component in order to obtain the Medicaid waiver from the Centers of Medicare and Medicaid Services. A key component of the Oregon Health Plan was that it used managed care as a delivery and financing system to control costs. Success of this plan was based on the availability of managed care organizations throughout Oregon. The OHP was funded through state funding, cigarette tax, and moving recipients into managed care plans. The OHP was successful in extending healthcare to 130,000 low-income individuals. While it was a success, it was badly affected by the economic situation that caused it to have cut enrollment, which in turn caused revenue drop in hospitals and pharmacies. Now back to you, Courtney.
Thank you, Jin. A state that wasn't so efficient and successful in establishing statewide health care is Tennessee. Tennessee placed their focus on expanding the role of Medicaid in order to provide some type of coverage for everyone in the state. All in all, it was poorly managed care. Right, Austin?
Exactly, Courtney. I'm reporting from Tennessee, where the state healthcare program, TennCare, has been struggling to accomplish the goals it set forth in 1993. The program was established to expand the Medicaid program to those previously uninsured or uninsurable. The foundation of this program was based upon the enrollment of recipients in managed care plans. Since only 2 of the state's 9 established HMOs and 20 PPOs chose to participate, it left a void to be filled by the state. In response, the state created 10 new managed care organizations specifically for TennCare recipients. Cost sharing was an essential element of the program. Premiums, co-payments, and deductibles utilizing a sliding scale based on income were required. Significant problems have been prevalent, though, throughout this program's history. Since the TennCare program was developed and implemented so quickly, there were many issues with organizing delivery systems. In addition, potential TennCare program recipients did not know which providers were associated with which managed care organization, or even which managed care organization participated in the program. Therefore, after some initial success, the program has periodically closed enrollment to the uninsured and uninsurable. More than 200,000 have lost their coverage through TennCare. Benefits were altered to match those offered by private health insurance, and a limitation on the number of prescriptions or refills that could be made per month was implemented. The TennCare program has experienced many problems due to the state's inexperience with this delivery system, as well as budget cuts. Now, thank you, Courtney. Back to you.
Another success story in the realm of healthcare coverage has been seen in Vermont with their implementation of the Healthcare Affordability Act. With this act, Vermont was able to insure many who had gone without insurance for some time previously. With more on this act and the progress in Vermont, let's go to Angela.
Thanks, Courtney. Here in Vermont, we have tried our best to increase access to health insurance. We have gotten support from both Republican governors and Democratic-controlled legislators to create a bipartisan support system. Our primary focus with these reforms is to get individuals to purchase health insurance policies. We also require employers to pay an assessment fee to help finance these programs. In May 2006, we passed the 2006 Healthcare Affordability Act, which created Catamount Health. This has helped many uninsured individuals, especially those who have been without health insurance for a year. We had set subsidized premiums on income. We also charged employers $365 a year for each uninsured employee in hopes of getting as many people as we could insured. The Healthcare Affordability Act has also created a chronic disease management plan called Blueprint for Health. Through this, we were able to incorporate early disease screening, all the while promoting patient self-management tools and financially rewarding healthcare providers for using proactive chronic care management. Since 2006, several other bills have been enacted to further the implementation of this act. In April 2010, we were able to pass a bill directing the State Health Care Reform Commission to prepare these financing options and implementation plans for these new healthcare financing systems. These financing options included single-payer, public, and an option that was influenced by the Affordable Care Act. As you can see, we have tried our absolute best to meet the needs of the people to better serve and provide for their health. Now back to you, Courtney.
Thanks, Angela. Reform in our healthcare system has seen many attempts over the years, with successes like the Hawaii Prepaid Healthcare Act, Oregon Health Plan, and the Healthcare Affordability Act, and failures like TennCare. At its core is the people's willingness to pay for changes to the healthcare system. But even with these implementations, healthcare reform in the United States is far from being complete. Signing off from Station 422, I'm Courtney Smith. Have a great night, and stay classy, D'Youville College.